So, a Bankart lesion, super common injury for anterior shoulder dislocations. In this video, we're going to show you exactly what it is and talk about some of the really important stuff to think about when it comes to our patients. Let's dive in. Hey guys, Khalid here. Welcome back to Clinical Physio. So to understand a Bankart lesion, first of all, we need to understand shoulder anatomy. So let's dive in to our 3D anatomy model. So the shoulder joint, medically referred to as the glenohumeral joint. And this is the joint between the head of the humerus or the arm bone and the glenoid fossa or the socket of the scapula, the shoulder blade. Now, you'll commonly hear the shoulder joint being described as a ball and socket joint. However, it's also commonly referred to as a ball and saucer joint. And that's because the glenoid, the actual socket that the arm bone sits in, is very, very shallow, as you can see here, much more akin to a saucer rather than a full socket. And what that means is that we find that the humeral head commonly is only 1/3 in contact with that socket at any one time. And that means it's very prone to instability and dislocations in particular. So that's why we have a really, really brilliant piece of adaptation from the body, which is the glenoid labrum. As you can see here, this is a soft tissue ring that runs around the outside of the glenoid. And it aims to almost deepen that socket to make sure that there's less instability when it comes to the shoulder. So what happens with a Bankart lesion? So the most common direction that the humerus or arm bone will dislocate is anteriorly, forwards, from back to front in relation to the shoulder. Now, if it does so with such force, it can end up tearing the anterior or the front portion of that glenoid labrum. And that results in this, which is what we can see as a Bankart lesion. So here is where we have an antero-inferior tear of the labrum. Anterior, front, inferior, bottom. And this is sometimes described as being almost between 3 o'clock and 6 o'clock on the glenoid if you were looking at a right-handed person, for example. Now, what we might even see with a particularly severe injury is a bony Bankart lesion, which is where, as well as the soft tissue of the labrum being injured between 3 o'clock and 6 o'clock, you also get a fracture of the bone from the glenoid itself, again in that 3 o'clock to 6 o'clock region, whereby the humerus is dislocated so hard that it's knocked off not only the soft tissue, but also a component of the bone as well. Now, this can be spotted on an X-ray, and it can look like this, where we can see there's that small slither of bone that has come away from that glenoid. And every patient who is suspected of having a shoulder dislocation should have an X-ray in the emergency department, meaning that they should be able to pick up on that bony Bankart lesion. And of course, if you see the bony Bankart lesion on the X-ray, you can almost guarantee that there has been the soft tissue Bankart lesion as well. So what's the problem here? Well, it means that the very tissue which is there to try and stop the shoulder dislocating anteriorly has been injured, which means that the shoulder or the humerus bone is more vulnerable to dislocating anteriorly. So a phrase that I have heard before, which I think is really apt, is it's almost described that a Bankart lesion is like the shoulder has lost its bumper. It's lost one of those key components that actually stops it from dislocating in the first place. And of course, that will increase the risk of dislocations for our patient in the future. So that's a Bankart lesion and exactly what it is. What do we actually find in practice? Well, your patient will commonly describe that they feel more unstable at their shoulder. They feel as if it has a higher risk of dislocating when they move it. Therefore, they're going to be much more apprehensive. They won't be using their shoulder as much. They won't be moving their shoulder as much. They are more likely to lose strength, particularly if they're rotator cuff muscles, because they're not moving. And so you can see how that psychology of, I feel like my shoulder is more unstable, has major physical complications as a result. So Commonly, patients might do a short trial of physiotherapy to try and see if they can improve their condition and reduce that feeling of instability. So here we might well be using some rotator cuff strengthening exercises because the rotator cuff is one of the key dynamic stabilizers of the shoulder joint. We'll also be using some proprioceptive exercises. Again, when it comes to instability, proprioception is key. And again, the idea here is to try and see if our patient can reduce that feeling of instability from physiotherapy. Now, of course, physiotherapy is always a good place to start, but I have to be honest with you, in reality, I think we see physiotherapy isn't always as successful in reducing that feeling of instability as we might like. As a result, patients still have ongoing issues, they still have ongoing pain, that feeling of instability, and of course that stops them going back to work or stops them doing their hobbies or their sports that are so important to them. And we almost feel as if there's a little bit of a cycle going on, because by having a dislocation of the shoulder, it increases your possibility of having a Bankart lesion. At the same time, having a Bankart lesion increases the risk of having further dislocations. And so, unfortunately, we find that patients may well go on to see an orthopedic surgeon to have a Bankart repair. This is where the surgeon will effectively stitch that glenoid labrum back and repair that Bankart lesion in the form of the soft tissue. But if that patient has also had a bony Bankart lesion, they will need that bone to be fixed as well. And therefore, you might find that they have a bone graft, a piece of bone taken from elsewhere in the body, commonly the iliac crest of their hip. And that piece of bone is then inserted into the front of the shoulder to reinforce that bumper that we talked about that the patient may have lost initially in the dislocation. Now, of course, if you have a patient or if you are a patient watching this video, please always consult the advice of your physiotherapist and your orthopedic surgeon for the best ideas of what to do. But otherwise, we really hope this video has been useful. If it has, please smash that like button and support our channel, subscribe for all our best updates, and of course, you can check us out on social media at Clinical Physio on Instagram, and check out our website clinicalphysio.com, loads of brilliant resources for the shoulder for all physiotherapists. My name's Khalid, thank you so much for watching, see you soon here on Clinical Physio.